Welcome to Clinical Tools Library, evidence-based scales and questionnaires designed to support healthcare professionals in practice. The modified Rankin scale assesses the degree of disability or dependence in daily activities after a neurological event, particularly stroke. It measures functional outcomes by categorizing patients based on their level of independence. The scale ranges from no symptoms to severe disability requiring constant care. Its main purpose is to evaluate recovery and guide treatment decisions in clinical settings and research. The scale is widely used due to its reliability and validity in monitoring patient progress and predicting long-term prognosis. The modified Rankin scale is indicated primarily for patients who have experienced a stroke. It is widely used to assess the degree of disability or dependence in daily activities following ischemic or hemorrhagic stroke. The scale is most useful in clinical contexts involving stroke rehabilitation, outcome measurement in clinical trials, and prognostic evaluation. It facilitates standardized assessment of functional status from no symptoms to severe disability. Its application extends to acute stroke management and long-term follow-up, supporting decisions on treatment efficacy and patient care planning. The modified Rankin scale consists of 7 items ranging from 0 to 6. The assessor asks structured questions regarding the patient's ability to perform daily activities and level of disability following a stroke or neurological event. Responses are based on observation and patient or caregiver reports. Scores correspond to levels of disability, where 0 indicates no symptoms, 1 denotes no significant disability despite symptoms, 2 reflects slight disability but independence in daily activities, 3 represents moderate disability requiring some help, 4 signifies moderately severe disability necessitating assistance with bodily needs, 5 indicates severe disability requiring constant care, and 6 corresponds to death. The assessor selects the item that best describes the patient's current functional status. Scores of 0 to 2 are generally considered favorable outcomes, indicating independence, while scores of 3 to 5 signify increasing degrees of dependence or disability. Consistent application of the scale requires careful adherence to the descriptions of each grade to avoid inter-rater variability. The scale uses an ordinal response format with discrete categories, enabling straightforward documentation of patient progress over time. The sensitivity of the modified Rankin scale reflects its ability to correctly identify patients who experience functional disability after stroke, while specificity indicates its ability to correctly classify those without such disability. In clinical studies, the modified Rankin scale has demonstrated a sensitivity ranging from approximately 85% to 95% in detecting moderate to severe disability when compared to detailed neurological assessments. Specificity values are generally slightly lower, often between 75% and 85%, reflecting some misclassification of patients with minimal or no disability. For instance, a sensitivity of 90% implies that 90 out of 100 patients with actual functional impairment will be correctly identified by the scale. Conversely, a specificity of 80% indicates that 80 out of 100 patients without significant disability will be accurately excluded by the scale. These performance metrics are dependent on the threshold used to define disability and the timing of assessment post-stroke. The modified Rankin scale was originally derived from the Rankin scale, introduced by Sir John Rankin in the 1950s to assess disability following stroke. Since its introduction, the modified Rankin scale has undergone extensive validation across diverse clinical settings and patient populations. Research conducted by Van Sweeten and colleagues in the late 1980s demonstrated the reliability and validity of the scale in measuring global disability. Subsequent studies have confirmed its inter-rater reliability, with weighted kappa coefficients frequently reported between 0.6 and 0.8, indicating substantial agreement among trained raters. Additionally, concurrent validity has been established through strong correlations with other functional and neurological outcome measures, such as the Barthel Index and National Institutes of Health Stroke Scale. The scale's sensitivity to change has also been supported by longitudinal studies showing its responsiveness to clinical recovery and treatment effects over time. Meta-analyses and systematic reviews further corroborate the modified Rankin scale's applicability and robustness as a primary endpoint in stroke clinical trials, emphasizing its foundational role in both research and clinical practice for measuring post-stroke disability. Thank you for watching. For complete information and official PDF resources, visit clinicaltoolslibrary.com or check the link in the description below. And don't forget to like and subscribe for more clinical insights.